Imagine looking at a pathology report. You're reading the genetic breakdown of a tumor, and you see that the cancer cells are highly mutated.
Right, like their DNA repair mechanisms are completely broken.
Exactly. The genome is chaotic, and the cellular structure is highly unstable. Naturally, you would probably assume this is, the worst possible scenario, like a wildly aggressive
Oh,
cancer.
absolutely. That would be the logical assumption.
But what if your oncologist walks in, looks at that exact same chaotic genetic profile, and tells you it is actually the best possible news you could get?
It is honestly one of the most brilliant paradoxes in modern oncology, and it fundamentally changes how we think about the biological arms race between a tumor and, the human immune system.
We are diving deep into that paradox today. You are getting an inside look at the official clinical practice guidelines for localized colon cancer, which is published by ESMO, that's the European Society for Medical Oncology.
And just to be clear, this isn't just some list of drug dosages.
No, not at all. It is the definitive playbook that dictates how doctors globally hunt, surgically dismantle, and chemically track this disease.
Okay, let's unpack this because reading through these guidelines, you really realize that managing colon cancer has shifted.
Yeah.
It's moved from this blunt force surgical approach to an incredibly precise molecular chess match.
It's a completely necessary evolution, though. I mean, we are dealing with a disease that is the third most common tumor in men
Yeah.
globally.
And the second most common in women.
Right. But the epidemiological landscape, like the who and the why, is shifting underneath our feet. Age has traditionally been the primary driver here.
Yeah, with nearly 70% of patients being over 65.
Exactly. But the ESMO guidelines highlight a very concerning spike in incidence among the 40 to 44 age group, specifically in Western registries.
Yeah, and the text specifically points the finger at westernization. Now, for an audience following oncology trends, we know that doesn't just mean eating junk food.
No, it's much more systemic than that. Right. The guidelines correlate this rise with a specific cocktail of lifestyle factors. We're talking physical inactivity, high red meat intake, smoking, and obesity.
Hmm.
But I want to look at the mechanism here, because the text points heavily to how these factors cause imbalances in the gut microbiota.
Yes.
We aren't just talking about digestion here. We're talking about chronic mucosal inflammation.
That's the core of it.
Yeah.
You have to remember, your gut microbiome is a highly active metabolic organ.
Right.
When you introduce the sustained inflammatory pressures of a Western lifestyle, you actually alter the bacterial composition. You start selecting for bacteria that produce pro-inflammatory toxins.
Oh, wow. So you're changing the actual environment.
Precisely. You alter how bile acids are metabolized. And this creates an inherently toxic microenvironment for the epithelial cells lining the colon. That's what drives the initial genetic mutations that kick off carcinogenesis.
Which brings us to the stepwise progression of the disease. It's the classic adenoma-carcinoma sequence. Instead of visualizing cancer as something that just, suddenly appears out of nowhere, it helps to think of the mucosal lining like the architectural matrix of a brick building.
That's a great way to picture it.
Right. So a single genetic hit, like an APC gene mutation, weakens the mortar. Over the years, subsequent mutations in genes like KRAS or P53 start shifting the bricks around.
Yeah, the structure gets weaker and weaker.
Exactly. And eventually, the structural integrity collapses entirely, which transforms a benign adenoma into an invasive carcinoma that breaches the submucosa. It's like catching a weed in a garden while it's still just a sprout, before its roots compromise the whole lawn.
And that slow architectural breakdown is actually our greatest clinical advantage.
Yeah.
Because the complete colonoscopy doesn't just find the weakened mortar, it allows the gastroenterologist to physically remove that dysplastic tissue before the wall collapses.
So it's simultaneously diagnostic and therapeutic.
Exactly. You find the threat and eliminate it in the same procedure.
Looking at the shifting epidemiology, though, I noticed a real tension in the guidelines. If we are seeing a documented rise in cases among that 40 to 44 demographic, why do the guidelines still draw a hard line at age 50 as the standard starting point for average risk population screening? I mean, it seems completely counterintuitive to the data.
I get that. It raises a really important question about the complex math of public health. When you are establishing guidelines for entire nations, you have to weigh population-level yield against finite healthcare resources.
So it's a numbers game.
It is. The absolute incidence rate in the 40-something demographic, while it is rising alarmingly, is still statistically dwarfed by the incidence in the 50s and 60s.
Right. Okay.
Recommending millions of invasive colonoscopies for average-risk 40-year-olds would completely overwhelm endoscopic capacity, and it would yield far fewer massive interventions per thousand screened compared to the older demographic.
So the strategy is basically to preserve the heavy resources for the highest yield demographic while aggressively isolating the outliers.
Precisely. The guidelines pivot hard toward stratifying individual risk. If you have a first-degree relative with colon cancer, or if you carry inherited genetic markers like Lynch syndrome.
Which involves mutations in those mismatch repair genes, right?
Exactly. If you have those, you are completely removed from the average risk pool. Your screening timeline accelerates dramatically, often beginning in your 20s or even your 30s.
Wow. Okay, so for those who do develop the disease, the transition from screening to diagnosis usually happens when physical symptoms actually appear. And mechanically, this tells us a lot about the tumor's staging, right?
It does. By the time you feel it, it's usually advanced.
Right. Symptoms like altered bowel habits, abdominal pain, or unexplained iron deficiency anemia, those generally indicate that the tumor has grown large enough to physically ulcerate or mechanically obstruct the lumen of the bowel.
And by the time localized symptoms manifest, the architectural matrix hasn't just collapsed. The tumor has essentially built its own chaotic infrastructure. And one of the most critical diagnostic concepts the ESMO guidelines introduce at this stage is the risk of metachronous tumors.
I found this biological implication completely fascinating. The data shows up to a 3% incidence of these metachronous tumors in the first 5 years after surgery, and that climbs to 9% decades later. And just to be clear for everyone, we are not talking about a metastasis where the original tumor sheds cells that implant somewhere else.
No, not at all.
We are talking about the body growing a completely distinct, brand new primary tumor.
Yes, it comes back to a concept known as field cancerization.
Okay, what does that mean exactly?
Well, if a patient develops a primary tumor in the descending colon, it means their entire colonic mucosa has been bathing in the same pro-inflammatory, dysbiotic, carcinogenic environment for decades.
So the whole area is essentially compromised.
Exactly. The tissue might look normal on a macro level, but on a molecular level, the entire field is primed with early genetic alterations. Removing the first tumor doesn't erase the genetic priming of the rest of the organ.
That perfectly explains the rigid necessity of lifelong surveillance. So once a primary tumor is confirmed, the medical team has to map the exact perimeter of the threat. The diagnostic workup mandates a full chest, abdomen, and pelvis CT to rule out distant spread.
Right, you have to see if it's moved to the lungs or liver.
And if there's an ambiguous lesion in the liver, they escalate to an MRI, leveraging its superior soft tissue contrast to differentiate a benign cyst from a hepatic metastasis. And they also draw blood for a CEA baseline, that's carcinoembryonic antigen.
Which is a vital piece of the diagnostic puzzle. CEA isn't used to diagnose the cancer initially because it lacks the necessary sensitivity, but it acts as a molecular barometer.
Like a tracking device.
Exactly. If a patient undergoes curative surgery and their postoperative CEA level remains elevated, specifically if it stays above 5 nanograms per milliliter, it acts as a biological red flag.
Because it implies there's still cancer somewhere.
Right. It strongly suggests that microscopic disease has escaped the surgical field and is metabolically active somewhere else in the body.
Which brings us to the mechanics of the surgery itself. The guidelines are incredibly strict about how the tumor must be removed. They mandate what's called an en-bloc resection. It's not about just carving out the visible mass, is it?
Not at all. That would be incredibly dangerous.
Right. The surgeon must remove the tumor, a wide margin of healthy bowel on either side, and the entire corresponding mesentery, which is the fatty tissue holding the blood supply and lymphatic drainage. And they have to do it in one intact, sealed package.
Yes, the integrity of the package is everything.
Because if they breach those fascial planes during surgery, they risk spilling microscopic cancer cells right back into the abdominal cavity.
The surgical technique is absolutely paramount for local control. But the guidelines also outline a very specific quota for the pathologist who's examining that resected tissue. They absolutely must isolate and examine a minimum of 12 lymph nodes.
Now, I was looking at that specific surgical rule. Mandating exactly 12 lymph nodes, not 10, not 15, it feels awfully precise. It seems less about anatomy and more about, like, a statistical threshold. Are they basically running a probability curve to prove the cancer hasn't spread into the lymphatic highway?
What's fascinating here is that you've hit on the exact mathematical reality of cancer staging. It follows a Poisson distribution.
A Poisson distribution?
Yeah. The lymphatic system is the primary drainage network for the colon, making it the most likely route for metastasis. If a pathologist examines only 4 or 5 nodes and finds no cancer, the statistical probability of a false negative meaning cancer is actually hiding in an unexamined node is dangerously high.
So you could think you're clear, but you aren't.
Exactly. But by the time you harvest and examine 12 clear nodes, the statistical confidence curve flattens out.
You essentially achieve mathematical certainty that the cancer is confined to the colon wall, keeping the patient at stage 2.
Correct. But if even one of those nodes contains tumor cells, the staging immediately upgrades to stage 3. And that singular distinction completely rewrites the treatment algorithm. It moves the patient from a surgical problem to a systemic one.
And that plunges the patient and the oncologist into the incredibly high-stakes math of adjuvant chemotherapy. The guidelines lay out the baseline survival odds after surgery alone. You've got a 99% 5-year survival rate for stage 1 that dips to between 68 and 83% for stage 2.
And it drops to 45 to 65% for stage 3.
Right. The biological reality is that surgery only removes the macro disease. Adjuvant chemotherapy is deployed to hunt down the micro disease, the invisible cells circulating in the bloodstream.
But deploying systemic toxins is never a zero-sum game. The guidelines present a conceptual Venn diagram for making this decision. You have to find the overlap between a high risk of relapse, a high expected proportional benefit from the chemotherapy, and a low risk of severe toxicity.
So if a patient doesn't sit squarely in the center of those 3 circles, the intervention might do more harm than the disease itself.
Precisely. You have to balance the scales perfectly.
Let's focus on that toxicity circle, because there is a molecular detail in these guidelines that is absolutely critical. It involves the DPD enzyme. Fluoropyrimidines, like 5-FU or capecitabine, they are the backbone drugs for colon cancer chemo. But they are inherently lethal, right?
Very much so.
The only reason they don't kill the patient is that the liver produces an enzyme called DPD. And this enzyme essentially acts as a chemical waste disposal shredder, metabolizing and clearing the toxic byproducts from the bloodstream.
Yes, dihydropyrimidine dehydrogenase. It is the critical metabolic safeguard for these patients.
Here's where it gets really interesting. Between 3 and 5% of the population carries a genetic mutation in the DPYD gene. This means they lack this metabolic shredder entirely. I mean, it's like downloading a massive software update on a computer that doesn't have the right operating system.
That's exactly what happens. The system crashes.
Right. If you give a standard dose of 5-FU to a patient with a DPD deficiency, the drug isn't metabolized. The pharmacokinetics go completely off the rails, the drug accumulates exponentially, and the toxicity becomes rapidly fatal.
It induces severe myelosuppression, essentially wiping out the bone marrow, along with catastrophic gastrointestinal toxicity. This is why the ESMO guidelines, in strict alignment with major regulatory bodies, now strongly recommend preemptive testing before a single drop of fluoropyrimidine is administered.
You have to know what you're dealing with first.
Exactly. You either genotype the patient for the DPYD mutation, or you phenotype them by measuring their basal uracil levels in the blood to see how well their existing enzyme is functioning.
And if they have a partial deficiency, the starting dose is slashed by 50%. If they have a complete deficiency, fluoropyrimidines are entirely off the table. It is the purest definition of personalized precision medicine.
It truly is.
But DPD isn't the only molecular marker dictating treatment. We have to circle back to the paradox we mentioned at the very beginning of the deep dive, the MSI or MMR status in stage 2 patients.
Yes. MMR stands for mismatch repair, and MSI stands for microsatellite instability. When a cell replicates its DNA, errors naturally occur. The MMR genes produce proteins that act as spell checkers, fixing those errors.
Okay.
If those genes are mutated and deficient, which we call DMMR, the spell checker is essentially broken. The tumor's DNA rapidly accumulates thousands of mutations, creating a state of high microsatellite instability.
And mechanically, this is where the paradox happens. You have a highly mutated, chaotic stage 2 tumor. But those mutations cause the tumor cells to produce heavily malformed proteins on their surface. These are known as neoantigens.
Exactly right. To the patient's immune system, a standard low-mutation cancer cell often looks enough like a normal cell to evade detection. It basically hides in plain sight. But a tumor covered in thousands of neoantigens looks glaringly alien. It's like a neon sign flashing for an invader. The patient's own cytotoxic T cells recognize the threat and mount a massive, targeted immune response against the tumor.
Because the immune system is already hyper-engaged, these patients, who by the way make up about 10 to 15% of stage 2 cases, have a significantly better overall prognosis.
Much better.
But the kicker in the guidelines is that trials prove these specific tumors derive absolutely zero benefit from standard fluoropyrimidine chemotherapy. By running this one molecular test, oncologists can spare 15% of their patients from months of toxic treatment that would only damage their healthy cells without hurting the cancer at all.
It completely flips our traditional understanding of tumor aggressiveness. However, for stage 3 patients, where the cancer has successfully breached the lymph nodes, the immune system has already lost the local battle.
Yeah, the dynamic changes.
The standard of care mandates a chemotherapy combination, typically FOLLFX or CAPOX. And this is where the conversation between doctor and patient shifts to the agonizing trade-off between securing a cure and accepting long-term neurological cost.
The heavy hitter in both those regimens is a platinum-based compound called oxaliplatin. The mechanism of oxaliplatin toxicity is uniquely brutal because it is cumulative. It doesn't just cause temporary nausea.
No, the damage builds over time.
It physically accumulates in the dorsal root ganglia of the nervous system, causing sensory peripheral neuropathy. The more cycles you get, the more the myelin sheath and axons degrade until you lose the ability to button your shirt or even feel the pedals of your car.
And that neurological damage is often irreversible. This specific toxicity drove one of the most important global research efforts detailed in the guidelines, the IDA collaboration. Researchers pooled data from over 12,800 patients globally.
That is a massive data set.
It had to be. The objective was straightforward, but incredibly bold. If we cut the duration of endless chemotherapy in half, from the standard 6 months down to just 3 months, could we maintain the same survival rates while sparing the patient's nervous systems?
The results on the toxicity front were undeniable. Dropping the duration from 6 to 3 months plummeted the rate of severe grade 3 neuropathy from 34% down to just 11%. I mean, you are saving thousands of patients from permanent disability. But did the 3-month regimen actually protect them from the cancer returning?
The pharmacological data revealed a crucial nuance. It entirely depended on the specific drug combination used. For the CAPOX regimen, which combines the IV oxaliplatin with oral capecitabine, 3 months was statistically non-inferior to 6 months. The efficacy held up.
Okay, that's great news.
But for the FOLX regimen, which uses intravenous 5-FU instead of the pills, 3 months proved inferior. It resulted in a measurable drop in disease-free survival.
So what does this all mean for the patient sitting in the chair? It means the doctor has to navigate the pharmacokinetics of how these drugs are delivered. The continuous oral dosing of capecitabine in CAPOX seems to synergize with the oxaliplatin effectively enough in 3 months.
Right.
But if a patient can't tolerate the oral drug and requires the IV infusions of FOX, the guidelines suggest they really need the full 6 months to get the maximum survival benefit despite the impending neuropathy risk.
It is a delicate, highly individualized calibration of risk, and the timing of when to initiate this risk is inflexible. The guidelines emphasize that adjuvant chemotherapy must commence within 8 weeks of surgery.
It's a pretty tight window.
It is. If postoperative complications delay treatment beyond the 6-month mark, the micrometastases have established themselves too firmly, and the survival benefit of the chemotherapy is entirely lost.
During this critical window, patients often feel completely powerless, just at the mercy of the chemicals. But the ESMO guidelines highlight lifestyle interventions that actually exert measurable biological effects on survival. They specifically call out physical activity and nut consumption. But the most fascinating mechanism involves a cheap, over-the-counter drug, aspirin.
Yes, but only for a very specific molecular subgroup. About 20% of colon cancers harbor a mutation in the PI3K pathway.
Right. The PI3K pathway regulates cell growth and survival. When it's mutated, it's essentially stuck in the on position, constantly driving the tumor to grow.
Exactly.
Aspirin acts as an inhibitor of the COX2 enzyme, and through complex intracellular signaling, COX2 inhibition downregulates that hyperactive PI3K pathway. You are effectively using a common painkiller to pinch the metabolic fuel line of a specific genetic mutation, leading to improved survival rates for that 20%.
It perfectly illustrates how metabolic interventions are becoming just as targeted as our chemical ones. But eventually, the active treatment phase concludes. The chemoports are removed, and the patient enters the longest and often most psychologically taxing phase of the guidelines.
Survivorship and surveillance.
Right.
The act of fighting stops, but the statistical reality is sobering. The guidelines note that between 30 and 50% of all patients treated for localized colon cancer will experience a relapse. The microscopic cells that evaded the surgery and survived the chemotherapy will eventually awaken from dormancy and proliferate.
While the overall relapse rate is high, the kinetics of when those relapses occur are highly predictable. The data shows that 80% of recurrences happen within the first 3 years following surgery.
So that's the danger zone.
That 3-year window is the undisputed danger zone, and the surveillance protocol is aggressively front-loaded to match it.
The schedule is intense. For those first 3 critical years, patients undergo clinical assessments and CEA blood draws every 3 to 6 months. They are subjected to full chest, abdominal, and pelvic CT scans every 6 to 12 months, searching for any macroscopic changes in the liver or lungs.
Plus the colonoscopies.
Right. They have a clearing colonoscopy at year 1 and then every 3 to 5 years thereafter. When you look at the frequency of that imaging, you realize patients are basically living scan to scan. The psychological toll, the anxiety of waiting for the radiologist to read that CT scan every 6 months, it must be overwhelming.
If we connect this to the bigger picture, this is precisely why modern clinical guidelines have evolved to dedicate entire sections to survivorship. Eradicating the mutated cells is only half the mandate. We have to manage the human being left behind.
Absolutely.
Beyond the psychological trauma of anxiety, there are profound physical alterations.
Especially for tumors located lower in the colon or rectum. The guidelines highlight low anterior resection syndrome, or LARS. Even after a successful surgery, patients suffer from erratic, persistent bowel dysfunction.
It's a huge burden.
And for those whose surgical anatomy required a permanent colostomy or ileostomy, the psychological distress regarding body image, social functioning, and high rates of sexual dysfunction are just life-altering.
It requires a paradigm shift in post-treatment care. The ESMO guidelines emphasize that oncologists cannot manage this alone.
They need a team.
Exactly. The protocol mandates integrating primary care practitioners, deploying dietary counseling for altered microbiomes, utilizing specialized ostomy nurses, and providing targeted psychosocial interventions. The objective isn't merely achieving a disease-free survival statistic.
It's enabling the patient to reclaim a functional, dignified life. Reclaiming the life that the disease tried to dismantle. That is the ultimate goal of this incredibly complex ESMO playbook. We've traced the biological journey from the subtle collapse of the mucosal matrix and the critical importance of a 12 lymph node surgical extraction to the high-stakes molecular math of chemotherapy, where identifying a broken DPD enzyme prevents fatal toxicity and understanding MMR neoantigens spares patients from useless drugs. We've seen how global data from the IDA trial weighed the preservation of nerve endings against the risk of relapse.
It represents a monumental synthesis of molecular biology, surgical precision, and human endurance.
And as we close out this deep dive, there is a provocative detail buried in the text that signals an impending revolution in how we track this disease. The guidelines briefly reference liquid biopsies, specifically the measurement of circulating tumor DNA, or ctDNA, which is currently being tested in massive studies like the Circulate IDEA trials. I want you to imagine a near future where the grueling routine of massive radiation-heavy CT scans and the anxiety of waiting for a mass to grow large enough to be seen on imaging are entirely obsolete. Imagine going to the clinic for a simple blood draw, and that single vial can detect microscopic fragments of mutated tumor DNA floating in your bloodstream in real time, months before a tumor ever forms. The molecular chess match is evolving faster than ever, and this blueprint we rely on today is about to be completely rewritten.